All right, everyone, welcome to the fifth week of the 2020 Pancreas Academy. My name is Greg Cote. I'm a professor of medicine and gastroenterologist at the Medical University of South Carolina. And this is our fifth week for those that have persevered, and I think we've saved the best for last. So thank you very much for joining us this evening if you're on the East Coast. So we'll have two talks, and then we will have at the conclusion, time permitting, an opportunity for moderated questions and answers. So throughout the first two lectures, please take the liberty of entering in the chat function questions, and I'll be taking note of them and do my best to address as many of them as possible at the end of the second lecture. You can also request to be unmuted during the Q&A section if you have a follow-up question, and our moderator, co-moderator will help to direct that component. So we have two talks from two outstanding faculty members. The first will be from Dr. Anna Phillips, who's an assistant professor at the University of Pittsburgh Medical Center. She's a pancreatologist and a rising star in pancreatology, and she'll be talking about an overview of acute pancreatitis, such a critically important topic for healthcare providers. And then we'll be followed by my colleague at the Medical University of South Carolina, Dr. Katie Morgan, who is one of the international leaders in pancreatic surgery, but also an outstanding pancreatologist. And she'll be discussing surgical therapy in pancreatic disorders during our second talk. And so without further ado, let me turn the mic over to Dr. Phillips at UPMC. Thanks, Anna.
Thank you so much. I wanted to thank Dr. Park and Dr. Cote for inviting me to speak this evening, and the organizers for making everything possible. And so let me go ahead and share my slides here. All right. Is that visible, Dr. Cote?
Yes, looks great.
Okay, perfect. Great. This evening, I'll be talking about an overview of acute pancreatitis. And so without any further ado, acute pancreatitis is an acute inflammatory event that originates within the pancreas and is associated with a wide variety of local and systemic complications. It's actually the most common disease that is diagnosed from a GI standpoint worldwide, and it accounts for over 270,000 hospital admissions per year in the United States. It accounts for an annual cost of over $2.6 billion in the US. Just to orient everyone tonight, we'll first talk about how to diagnose acute pancreatitis, etiologies of the disease, then manners of determining severity of the disease, management, including aspects of IV fluids, antibiotics, nutritional support, and then lastly, perhaps most importantly, complications. A patient can be diagnosed with acute pancreatitis if they meet at least 2 out of 3 of the following criteria. So they have to have typical upper abdominal pain, usually epigastric, sometimes radiating to the back, and a serum amylase or lipase level greater than 3 times the upper limit of normal of the serum assay. They also need to have imaging findings consistent with pancreatic inflammation, usually on CT scan, which would be the most common way to discern that. The most common etiologies of acute pancreatitis in the United States are gallstones and then alcohol. On the left-hand side of the screen, you can see a long list of other potential causes that fall into that other or miscellaneous category, but by far the most common two are gallstones and alcohol. There remains a lot to be known and discovered still about the pathophysiology of acute pancreatitis, but in this diagram, you can see some of the major pathways that have been discovered and elucidated. Over here on the left, you can see evidence of a gallstone that would have traveled down the common bile duct in order to be lodged just adjacent to the sphincter of Oddi, where the pancreatic duct and the common bile duct are going to join. This can cause transient ductal obstruction in the pancreas and increased intraductal pressure, resulting in backup of pancreatic enzymes, and then acute pancreatitis as a result. Alcohol, when added to cholecystokinin, can also trigger intracellular events that result in the uncontrolled release of trypsin and other enzymes, which can then cause autodigestion of parts of the pancreas and subsequent inflammation. The majority of etiologies of acute pancreatitis cause some combination of increased intraductal pressure in the pancreatic ductal system and uncontrolled activation of trypsin. And both of these together can then exacerbate. Here on the left, you can see in an ultrasound image the black outline of the sac-like gallbladder, and then inside there you can see some degree of layering sludge or microlithiasis, which can be responsible for acute pancreatitis. And then over on the right, you can see another ultrasound image of the common bile duct where there is sludge and possibly even a small stone included. In the lower right-hand corner, you can see in this diagram the path of the gallstones, which are traveling down the common bile duct and get lodged at that location where the pancreatic duct and the common bile duct join, thereby causing transient pancreatic duct obstruction, which is a common cause of acute pancreatitis. There is a very clear association between alcohol and acute pancreatitis, but there is actually no established threshold for a specific volume of alcohol that is consumed and an associated risk of acute pancreatitis. We do suspect, though, that in patients who develop alcoholic acute pancreatitis, that there is an elevated underlying susceptibility, even though in the vast majority of those patients, we haven't identified what that component necessarily is. It's important to remember that many of these patients will have been drinking steadily for many years before they might first manifest with acute pancreatitis at that threshold, whatever that individual level may be for them. In general, we can counsel patients that there is an increased risk of all alcohol-related disorders, though, with either daily alcohol consumption of more than 3 drinks a day for women or more than 4 drinks a day for men, or weekly alcohol consumption of more than 7 drinks a week for women or 14 drinks per week for men. And so in any patient who has alcohol-related disorders, specifically acute pancreatitis, abstinence is always the best strategy in terms of maintaining the lowest possible risk of recurrent episodes. Here is an inclusive but not exhaustive list of other causes of acute pancreatitis, again, including things like metabolic causes, iatrogenic, autoimmune, medication, cancers, structural, infectious, traumatic, inherited, vascular, and this can be further lengthened most likely. If a patient is determined to have none of these identified causes, then their pancreatitis is termed idiopathic. It's very important to remember that acute pancreatitis is an extremely dynamic process. And so there is very rapid progression often during the first 24 to 48 hours of the onset of acute pancreatitis. Early assessment is key for these patients, and it's important to assess which patients are going to progress to severe disease. It's also important to therefore start supportive therapy immediately. The vast majority of patients, about 80%, will have a mild, uncomplicated course, and if they're admitted to the hospital, they'll be discharged within a few days. But up to 20% of patients can develop a severe clinical course, and this might include things like the systemic inflammatory response syndrome, or SIRS, multi-organ failure, or pancreatic necrosis. And within this severe group, there's up to 30% mortality. Overall, though, all acute pancreatitis patients included, treatments have improved so much that only about 2% of patients will experience mortality from this. Over 50% of those deaths, though, do occur within the first 2 weeks of diagnosis. As I mentioned, there's a huge import that is placed upon identifying which patients are going to progress to a severe course of disease, since those are the ones who end up with complications and risk of mortality. Here in this publication from 2012, which compared multiples of these scoring systems to each other, you can see that some of the more complex scoring systems, they perform relatively well in terms of predicting which patients are going to develop a severe course of acute pancreatitis. It's also important to acknowledge, though, that more simple scoring systems, such as just accounting for which patients have systemic inflammatory response syndrome, or even simple lab tests like a BUN level or creatinine level, perform almost just as well in a much less encumbered manner than trying to perform complex scoring systems. Just so that I'm clear on exactly what I'm talking about with the Sears criteria for anyone who may not be aware, the Sears criteria would include tachycardia, a heart rate of greater than 90 beats per minute, core temp that's either lower than 36 or greater than 38 degrees Celsius, a very low or very elevated white blood cell count, and then tachypnea or respirations greater than 20 per minute. The most common way by which we decide the severity of acute pancreatitis is performed with the revised Atlanta classification of disease, which divides patients into 3 categories. That can be mild acute pancreatitis with no organ failure or no local or systemic complications, moderately severe acute pancreatitis with organ failure that resolves within 48 hours, or local or systemic complications without organ failure, and then severe acute pancreatitis, which includes persistent organ failure. It has to persist at least 48 hours, and that can be either a single organ or multiple organs, examples of which are seen below. Some patients are going to be predisposed to have a more severe course of acute pancreatitis. And in this figure, what you see is that patients with a BMI of greater than 30 have higher rates of organ failure, necrosis, and death in acute pancreatitis as compared to those patients with a BMI of under 30. This is thought to be due to the fact that adipose tissue or fat cells release adipokines that can worsen inflammation in the setting of acute pancreatitis. These include things like TNF-alpha, resistin, visfatin, etc. Here, I'll take just a moment to mention the pancreatitis activity scoring system, which takes all together the presence of organ failure, intolerance to diet, systemic inflammatory response syndrome scores, presence of abdominal pain, and then IV pain medication use into a single score that is then designed to predict meaningful clinical outcomes or identify points where patients may have a change in their course overall. There's actually ongoing work to try and validate this score and improve it in larger populations, but I mention it here just because you may see this in the future as a means of measuring the activity of a patient's pancreatitis during their hospital stay. There is no drug therapy that is available to treat acute pancreatitis. And this is very important because the tenets of treatment for acute pancreatitis all revolve around supportive care. The first and most important is to correct the primary insult to the pancreas. This can take multiple forms, but might include things like early ERCP. Certainly you want patients to cease all alcohol use, and you want to correct metabolic abnormalities like triglycerides or calcium levels. Certainly fluid resuscitation is a very important part and an aggressive part of supportive care. Also, we need to think about nutritional therapy, pain control, and perhaps most importantly then, prevention of future attacks. A brief note on the role of urgent ERCP. Early ERCP in patients with biliary pancreatitis and then concomitant cholangitis, infection in the bile duct, or a high suspicion of persistent bile duct stones is definitely appropriate. The presence of bile duct stones can be assessed by CT or MRI, MRCP, sometimes even by endoscopic ultrasound. However, the role of early ERCP in predicted severe gallstone pancreatitis in the absence of the above is controversial and has to be decided on a patient-by-patient basis. Fluid resuscitation is also a controversial topic, but it has to be acknowledged that this is actually the cornerstone of therapy in acute pancreatitis. In patients with severe acute pancreatitis, fluid accumulates in the third space or the interstitial space due to vascular leak syndrome. And therefore, inadequate hydration in these patients can lead to hypotension, renal dysfunction, and damage to the pancreatic microcirculation. Fluid resuscitation, therefore, takes the form usually of a 1 to 2 liter bolus as a patient gets admitted to the hospital, followed by 150 to 200 milliliters per hour of IV fluid for at least 48 hours. Lactated ringers tends to be the preferred therapy. Theoretically, this fluid can decrease pancreatic acidosis and therefore reduce trypsin activity. But it also has to be acknowledged that the optimal amount and composition of fluid remains unclear, and this question remains still understudied and unanswered. Also, practice varies widely between centers. And so assessment of the adequacy of fluid rehydration is actually usually assessed by individual providers via improvement in vital signs, urine output, and correction of hemoconcentration measures. This table from the apprentice study, which looks at over 1,600 acute pancreatitis patients who were enrolled around the world, highlights a couple of the points about differences in management strategies across different centers. Here you can see that intravenous fluids, actually there's a wide range of both amount of fluid and type of fluid that are given from between centers in different continents. And similarly, pain management differs quite significantly between centers as well. Of interest is the fact that up to 93% of patients actually in North America receive opioids during their inpatient hospital stay, whereas that's very different actually on other continents. Nutritional support for pancreatitis patients should usually be started by an attempt, at least, at oral feeding within 24 hours, as this is tolerated by patients. Many patients, though, will have oral intolerance to feeding, and so nutritional support is definitely required when patients are predicted to remain fasting for more than 7 days. Enteral feeding via a nasogastric tube or a nasojejunal tube, seen up to the right, is preferred to total parenteral nutrition or IV nutrition. This is because it tends to maintain the intestinal barrier and protect against bacterial translocation. It also eliminates the possibility of central line associated infections. And a previous large meta-analysis that was done on this topic showed a reduction both in infectious morbidity and hospital length of stay, as well as a trend toward reduced organ failure. There is low quality evidence supporting the role of prophylactic antibiotics in acute pancreatitis, and guidelines from multiple GI and pancreas societies actually recommend against the routine use of these. And so I do want to be clear, though, that in the situation of infected pancreatic necrosis, which we'll talk about, there is a clear indication for antibiotic therapy, and that's absolutely appropriate. There are many systemic complications of acute pancreatitis that can include cardiovascular complications, pulmonary, renal, and metabolic systems. Some of the most important local complications, though, are fluid collections. And so there are 4 main types of fluid collections according to the revised Atlanta classification. And these include acute peripancreatic fluid collections, pancreatic pseudocysts, acute necrotic collections, and walled-off necrosis. And so from top to bottom on this slide, you go from the acute setting, which are peripancreatic fluid collections and necrotic collections. Pancreatic fluid collections tend to be simple fluid, either inflammatory fluid or pancreatic enzymes. Necrotic collections are due to necrosis or autodigestion of the gland itself. And these evolve into their respective counterparts after 4 weeks of time into pancreatic pseudocysts or walled-off necroses. And so here you see them in a slightly different format, but from left to right here, you can see acute pancreatic fluid collections are evolving into pancreatic pseudocysts, and acute necrotic collections are evolving into walled-off necroses, respectively. Here you can see the clear evolution from normally enhancing pancreas through walled-off necrosis. And so on the left, you see a normal enhancing pancreas in the setting of acute pancreatitis, transitioning to a necrosed pancreas in the middle. And then on the right, you can see the actual granulation tissue wall or capsule that has formed after about 4 weeks. Now, pancreatic necrosis is truthfully rather rare, but approximately 10 to 20% of patients admitted at tertiary medical centers will have this. And so we see it more often in larger medical centers. Infectious complications can occur in up to 20 to 30% of these patients. And oftentimes the infection or the superinfection occurs about 2 to 5 weeks out. This can manifest with new fevers or new symptoms like abdominal pain, nausea, vomiting that may have initially resolved after the acute episode of pancreatitis. Septic complications from infected necrosis often account actually for most of the late deaths in acute pancreatitis. And so management of these fluid collections is of central importance. You'll likely hear more of this from Dr. Morgan in just a few moments. But in some patients who are stable and where there is not infection concerned, conservative treatment can absolutely be appropriate. However, in patients where there is suspected infection and instability, an intervention is usually needed in the form of a drainage or necrosectomy procedure. There are many different techniques for achieving a drainage or debridement of these pancreatic fluid collections. And so internal drainage can be achieved by endoscopic debridement. In the right upper corner, what you can see there is a cyst gastrostomy where a lumen apposing stent has been placed in order to drain the necroma, which is adjacent to the stomach, directly across the wall of the stomach into the gastric lumen. It then drains out through the intestines, and the lumen apposing metal stent is removed several weeks later. External drainage can be performed by placing a drain, usually by ultrasound or CT guidance. And so in the middle diagram, you see a drain placed into the necroma with an external bag that collects the fluid. Drains can also be placed surgically. And then surgical debridement, again, Dr. Morgan will likely talk about this further, but here a minimally invasive approach is usually taken in order to avoid open necrosectomies because of the high morbidity that is associated with these open procedures. And in the lower right-hand corner, you can see an incision made in the stomach wall surgically allows a necroma then to drain in a similar fashion into the gastric lumen. This is a key publication that actually reviewed the import of a step-up approach, or using the least invasive but effective approach in a step-up manner in direct comparison with open necrosectomies. And so this was a randomized controlled trial of 88 patients who had suspected or confirmed infected pancreatic necrosis. And the composite endpoint here was either new onset organ failure, perforation or bleeding, or death. And this occurred in 40% of patients who underwent step-up therapy, but 69% of patients who underwent an open necrosectomy. A brief note on long-term sequelae of acute pancreatitis. Patients with acute pancreatitis will sometimes have just one episode and never have another if they're very lucky. Oftentimes, too often, we see patients who have recurrent episodes of acute pancreatitis and might, in their sentinel event of acute pancreatitis, actually be placed along a spectrum where they could progress through repeated episodes of inflammation to then develop chronic pancreatitis due to irreversible fibrosis. Patients can also develop exocrine pancreatic insufficiency, which is the loss of the ability of the pancreas to produce enough digestive enzymes to maintain sufficient nutrition. And up to 40% of patients, it's been seen, may actually experience some symptoms of this within the first year after acute pancreatitis. This can be tested with a fecal elastase 1 level and often treated with pancreatic enzyme replacements. Pancreatic endocrine insufficiency, otherwise known often as type 3C diabetes, can result from the destruction of pancreatic islet cells and can be a very brittle, difficult to control form of diabetes. On a last note, just because of the import of this in the world in which we are currently living, is a brief note about acute pancreatitis and the novel coronavirus, or COVID-19. And so up to 50% of COVID-19 patients are known to have at least one GI symptom when they present. But clinically severe acute pancreatitis is actually very uncommon in COVID-19, even though there have been several case reports published to date. It's important to remember that acute pancreatitis can be precipitated by vascular insults in the setting of hypotension, and also that enzymes can be elevated for multiple reasons. And so in one study of 52 patients from Wuhan University in China, it was noted that 9 or 17% of these patients had mild elevation in their pancreatic enzymes, and these patients had a higher incidence of anorexia and diarrhea. These patients also had more elevated blood glucose levels, which is of perhaps important, of import because of the connection between more severe COVID-19 and diabetes, though this connection hasn't been further proven in pancreatitis patients. And so in summary about acute pancreatitis, points to remember, the diagnosis is based on 2 out of 3 criteria. Gallstones and alcohol are the most common etiologies. Severity is usually determined by the revised Atlanta classification. Management of greatest import is going to be IV fluids and pain control, and then prevention of future attacks. And not to be forgotten are complications. And so these can include necrosis and fluid collections, and then long-term, continuing to screen patients for the risk of exocrine pancreatic insufficiency, diabetes, and chronic pancreatitis is also of great import. And so with that, I'll end and say thank you for your attention and ask if there are any questions.
Thanks, Anna. This is great again.